Matthew Timmins,
Hi.
thank you for giving me your time. We're here to talk because you had medical adventures or misadventures that happened to you. Can you tell us in your own words what you had, the symptoms you experienced, the surgery you underwent, and how you live with that today? It's a lot of that, Matthew, but let's take it one at a time.
Okay, so I'm just going to rewind a little bit to 2006.
Okay.
And that's pretty much when I got my diagnosis of inflammatory bowel disease.
Okay.
I was quite worried at the time because I had a lot of symptoms, going to the toilet a lot.
A lot of bloody diarrhea.
Bleeding, a lot of urgency. Eating food was really difficult. I mean, for example, on my way to work, I couldn't eat before I went to work. And I had to try and make sure I went to the toilet before, as soon as I got to work.
So the disease was beginning to run your life.
Oh, pretty much.
Yeah. And then from a physician point of view, we would give you medicine. And that medicine would try and get that disease under control. Not necessarily cure it, but get it out of your life and make it a periphery in your life. It's fair to say that we had limited success with that. Will you tell us a bit about that?
Yeah, I mean, I pretty much took most of the IBD medications out there. From some of the starter drugs, and what would happen is they'd work for a while. They'd work for a set time, and I'd reach what you call a stage of remission.
Yeah.
So that's where you kind of live in.
What would you call? Yeah.
Yeah, you kind of live in each day. You'd still know you've got the disease, and you may have some background symptoms, but you're not overly disadvantaged in your day-to-day living with it. So
I would boil that down to you were able to carry out your activities of daily living.
Yeah.
You had a decent quality of life.
Yeah, sure.
Okay. For a limited amount of time for each medicine.
That's right. Yeah.
Okay.
And I always kind of ended up bouncing on the steroids because what would happen is you'd have a medication that worked for so long.
Yeah.
You'd end up in an IBD flare, and the go-to medication would be a steroid medication, which unfortunately isn't that good long term.
Sure.
For anyone, and that would pretty much be the cycle all the way up until I needed surgery.
Yeah. It's fair to say that steroids can they're a little bit like a hammer. They kind of hit the nail in for a while, but then the nail, when it comes back up, you have to use. And steroids are fair enough for short term, but repeated courses of short term steroids do tend to build up in terms of side effects.
Absolutely, yeah.
Yeah. So we gave you all these medicines. It was a full frontal sequential assault, medication after medication.
Yeah.
And I always tell patients and students that we always resort to our surgical colleagues, ask them for their opinion when medicine has failed or there's a complication of the disease. I think you were nearing one of these things, weren't you?
Yeah, I mean, I would often be discussed on what you call the MDT.
Yeah, that's the multidisciplinary meeting where we all gather around experts, surgeons, physicians, radiologists, specialists, nurses, pathologists, junior doctors, everyone, and just really scrutinize the case and come out with what we think might be the best way forward.
Yeah, I mean, I was pretty much always discussed there for a good time because it was complicated. And I'm a complicated patient. I think that's that's something that people are going to relate to, because there are a lot of people out there that hear this phrase, you are a complex case.
Yeah.
And as soon as you hear that, you feel, what does this actually mean?
Okay, it means I can't just say, good afternoon, Matthew, I know what's wrong with you, I've made a diagnosis, here are the medicines, you'll be fine. But because that happened for you for a while and then you would come back. Because the disease, in your case, was inflammatory and insulting enough to
very aggressive.
Aggressive. That's a better word. Yeah.
Really aggressive.
To push away a lot of these medicines. So that's what makes it complicating.
Yeah.
So how did surgery loom in the horizon?
Okay, so for me, just a little background is that I also have a liver condition called PSC.
Okay.
So that in simple form, what that means is my liver doesn't work as well as a normal liver, and bile doesn't flow through, which your liver detoxifies your body. So what happens is the bile doesn't flow through my bile ducts versus, say, someone else.
I know it well, Matthew. I know it well.
Okay. Now, the complication with that is a lot of PSC patients, like myself, have a liver cirrhosis, not from alcohol, but from the disease.
Correct.
So now we enter a stage of we have a patient who needs our help surgically, but it's possibly unsafe. And that's exactly what happened to me.
Okay. So what you're telling me is, again, you're extraordinary because you're not...
I'm just extra.
Yeah. You're not Matthew Timmins with inflammatory bowel disease.
No.
You're Matthew Timmins with PSC and inflammatory bowel disease. What that means is it does make the surgery a little bit more riskier. Not much more, because our surgeons are so good, if I say so myself.
Yeah.
We just have to be cognizant of that, because your liver isn't top notch. I think that's fair to say.
Yeah.
Because you have this disease which needs to be monitored, and that we have no obvious clear medication or therapeutic targets for, you know?
Mm-hmm.
So I understand that. This is important for other patients to think about. How was the conversation about surgery, Matthew?
Okay, so it's actually something I approached on a couple of occasions.
Okay.
Before I actually reached the stage of 100% you have no medication now. I had a conversation before that, and in that conversation we spoke about exactly what we do, you know. And for me, it was always going to be, if I did have a stoma, if I needed surgery, it would be a permanent stoma.
Yes.
So I had to kind of come to grips with that. I'd say around 3 to 4 years before my actual surgery took place.
Okay, at that stage, when the surgeon said you need a permanent stoma, you know, like when people tell us things and we don't understand what it looks like, feels like, whatever, what were the images conjured in your mind? Like, what was coming out? Because you're new to this.
To a degree, I've always known people that have had surgery through the online support groups, and I recommend the online support groups always. But it's still a big thing to get your head around, because what you're talking about is a permanent change to your body.
Totally.
And you know, in your mind, you're always thinking, I hope this is a good change for me. But in your mind, you're also thinking, could it be a bad one as well?
Yeah.
So you have to come to terms with that. You know, it's not an overnight process, is what I'd say. It's an individual journey, and you've got to take it one step at a time.
So you had to just, I mean, in common parlance, you had to get your head around it.
Oh, massively. Yeah.
So anything else, Matthew, that helped you get your head around it? You were already at an advantage. You knew people with stomas.
Yeah.
So you could pretty much, putting words in your mouth, go around, have a chat. Can I see the stoma? What's it like? You had all that information.
Yeah.
Did you resort to anything else? Were there nurse specialists? Was there a surgeon?
I'll tell you what happened. Not long before I had my stoma surgery, okay, in the lead up to the period I was in hospital, in the period, the stoma nurses actually gave me a pretend pouch and a pretend stoma, if you like, to glue on and practice, you know, so you can kind of get used to the feel, how that would be.
Okay,
you know?
okay.
And what they involve is you'd stick this on your abdomen.
And you go around for the day.
You'd fill it up with what, you know, without being too crude, like, you know, say like some porridge or something like that, which would kind of be the same as, you know, someone with a stoma. Okay. And you kind of get used to that weight.
Okay.
You get used to carrying it around.
And that, you're telling me that helped?
It helped massively.
Yeah.
And I would just say, don't be afraid of having the conversation with your loved ones, your children in particular. My kids, I remember, they won't mind me saying this at all, they were pretty young at the time, and I'd kind of spoke to them and kept it really simple. And I remember them both saying...
Were they pretty cool about it?
All they actually said was, oh, so basically you're going to poo on your tummy now, Dad? It's no big deal.
See,
it's like that. It was that way of looking at it, which was really refreshing.
Well, that's simplified and correct.
Yeah.
And it's just that technology allows us to do that in a very user-friendly fashion.
Yeah.
Yeah. So, was there any particular point where you went, right, I've got my head around it now, I'm ready? Or was it just a gradual
Well,
dawning?
to a degree, I was in a very, very dangerous health position.
Okay.
So to clarify, January 2019, I've been hospitalised. All the medications failed now. The doctors have said to me, you have to have surgery.
Yeah. So basically you were going back to that kind of failed medication.
Correct.
Yeah.
Here's the issue. Because of the PSC and the complications, I couldn't have surgery. I had complications with my liver, and my liver was failing, and it was pretty bad. So it was 50-50 whether I'd need a liver transplant or even whether I'd come through the operation.
So it's not that, well, you could have had surgery, but the risk was far too high.
The surgeon wouldn't be able to,
yeah,
because they have to keep repairing the blood vessel.
Yeah.
Because just to explain for everyone, with PSC you can get what you call esophageal varices.
Correct.
Little veins that pop and bleed in the abdomen.
Like hemorrhoids.
Yeah, sorry, in the esophagus. And this is a deadly thing, so they have to be so careful. So they actually fitted me with a liver stent called a TIPS, which reduces the pressure in the portal vein system.
Correct.
So that's your bowel, your liver, your spleen, your gallbladder.
You explain it really well.
It's my body. I always thought, if I can't do it, I've got no chance of getting someone to help me. So
that's very good, man.
I've really got to, kind of have someone.
So you had the TIPS as a kind of, in order to push your body towards a safer outcome from surgery.
Absolutely.
Yeah.
Risk reduction, and that's all anyone can do with surgery. I'll never say to people, surgery is 100% going to help, 100% not going to help. You don't even know, but you've got to put your faith out there. If you've been told you need surgery, I think it's, you have to listen to the experts.
And it's also a really clear message you're sending, Matthew, in that you can do a lot to optimize yourself for surgery. You had the tips, and this is a general surgical point. People can lose weight, stop smoking, get fit, go to the gym, build some muscle, because surgery is essentially an assault in your body.
Yeah.
And afterwards you're going to have to repair and regenerate, and you need to be in good shape to do that.
I mean, I could do an hour talking just about that bit there, but it's one of my passions, because I think at post-surgery, to be ready for post-surgery, you have to be ready before, which is the weirdest thing mentally.
That's
you
right.
think to yourself,
That's right.
how am I getting ready for something I haven't even done yet? But you really do have to.
But Matthew, people don't just turn up on the London Marathon on the first day. They prep. And it's a bit like surgery is an assault, and you have to really prep for it, mentally and physically, I guess.
It is both. And I will say, I think what happens is people that are coming to that stage, they're not very well. So someone might be watching this now thinking, oh, well, he's saying go to the gym, he's saying work out, he's saying do this. Do a little bit of something versus doing a lot of nothing. And that's going to be really, really beneficial. So even if it's slight, you can walk halfway up the road and come back, and you do that once a day. Maybe you do twice a day afterward, and this just adds to your cardiovascular health, and it reduces that risks post-op infection risks and things like that.
That's a massively useful perspective.
Yeah.
So the day comes. Go on, tell me in kind of, how did it all, from your point of view, how was the day and how was it afterwards?
The day, you'll be really, really nervous.
Yeah.
And it's absolutely normal. Okay, it's absolutely normal. Because you're going through, you have all these uncertain thoughts in your mind.
Yeah.
You're thinking, I don't know what's gonna. You'll be explained. You'll have the anaesthesis.
You're vulnerable.
Yeah. To a degree. I mean, you've gone through the pre-op stuff, so they've explained what's going to happen.
Yeah.
They've usually gone through what pain relief or what kind of medications they're going to use after. Do you mind if I tell a quick story on?
Please.
Okay. So what happened with me? The anaesthetist said to me, he says, when you come round, you won't be quite in the real world. And I didn't really know what he meant. And I thought, I don't know what he's trying to say to me here. Anyway, I'd had the surgery, I'd come back round. Okay. And I remember reaching for this glass. I was just not in the critical care bit, I think in a little bit after that, the resting place or whatever. It's a glass of water. I sort of reached for a glass of water. And as clear as I'm seeing you now, I could actually see a dancing crocodile in a cowboy hat. Straight up. It was literally there.
In the glass
yeah,
of water?
Literally there. That's no joke. That's how it happened.
Okay.
And it was the medications they'd given me.
Yeah.
Now, just to revert back, because of the PSC I got, they couldn't give me an epidural. Okay, so it's too dangerous. So they had to give me a concoction of 3 medications direct into my abdomen for the pain. Okay.
This is after the surgery?
No, this is during the surgery.
Okay.
It's during surgery. It was explained to me that we were going to do this. Okay. So this may not be the case for most people. A lot of people will be able to have an epidural or other pain relief that suits them. It's very important to have that discussion. But I know one of the medications was ketamine, so it was like, okay, that's strong stuff, you know. But I just remember that memory so well, you know.
So you arrived, you were so informed, you were in a good place before you went under, so to speak. The surgery would have been at least an hour or two. Six
for me.
Because you were special again.
Yeah. Okay. My poor wife had a phone call off the surgeon because they had a complication. Basically, my spleen, the way your spleen sits, it's not too far from the bowel as well. And with the liver disease, I had the spleen had enlarged.
Correct.
And got in the way.
Yeah.
And weren't sure what to do. So what I had to do, kind of during the operation, was just take a bit of a pause.
Yeah.
Okay, they just paused for a little bit, and then they came back in, and they managed to do it in and around the enlarged spleen.
Okay.
Which, if you can imagine, is like trying to get to work in the middle of a traffic jam.
I told you. I told you our surgeons are good though.
Yes. Especially here at the QE. But yeah. You know, I was very fortunate with that, you know, but 6 hours, you're going to be out of it when you wake up, like, you know, and then just take it from there, really.
So, but the immediate change, when you come round and the dancing crocodiles have all gone away, the immediate change is what is on your belly now.
That, yes.
Yeah.
I had this thought in my mind, what if they were unable to do it? And when I looked down and I saw a stoma, I was just really happy with that.
Yeah.
They've been able to do this.
They've been able to do it. It's been.
I had a feeling that we were going to get through the operation. We were going to get some complications, like I did have some kind of complication, and then go, we're really sorry, it was too dangerous. We just couldn't do this for you.
Passing.
And I think that's a good thing for people to again listen to, because they may not be as complicated as myself, or hopefully not, you know, and they may come round and go, actually, you know what, I'm okay. I don't feel too bad. And it was actually the next morning was the biggest change, because every morning since 2006 I'd wake up, I'd have this pain, and it'd be a severe pain. I'm pretty sure it was left-sided, you know, go back a few years now, and I woke up and there was no pain, and it was such a massive difference for me. So I was like, where's I felt like I was in a different body, you know, because I was like, where's this pain I'm used to having every day? And it wasn't there. It was because, you know, they'd removed my large colon, you know. But yeah, that's where I was.
So that's the first immediate win.
Oh, massively.
Yeah.
The next one for you is they're going to ask you to sit up, which is probably something like a quarter of a sit-up, okay? Which doesn't sound that a lot, but when you've effectively got no abdomen the next morning, it's like doing 1,000 press-ups.
It's like going out of a mountain. Yeah.
Trust me,
yeah.
And it's one of the hardest things you'll ever do. You'll have a nurse like either side, and you'll just feel like, I can't do this, I can't do this, I can't do this. But when you do it and you're upright, you'll feel it, and you'll be like, oh, okay, I did it. And then that'll just start adding to your recovery and stuff.
So the stoma starts working.
Yeah.
Matthew, what does it look like? What does it feel like?
Basically, it's you've got an organ on the outside of your body.
Yeah.
So usually, if it's healthy, it's pink.
It's a protrusion of healthy bowel, isn't it?
Yeah, basically.
And it's there, sticking out.
You've got it there, sticking out.
And it's then it starts to work.
And it starts to work. For some patients, they might not have it work immediately. You know, it might take a little while. There's a lot of things they'll encourage you to do. Again, they'll try and get it to move around as much as possible. And that can encourage movement. Once it starts working, it's great, because then usually what happens is the stoma nurses will change your bag for you to the start, and then they'll start training you on how to change a bag yourself, which is a real big thing, because that adds to your independence then, and you can like, oh, I can do this myself, I don't need someone to.
So the bags fit around the protruded bowel.
That's right.
And adhere to your anterior abdominal wall.
Yeah, that's it, yeah.
Yeah, and you are trained to, and I'm hoping you'll say it's straightforward, to change those bags on a regular basis and get into a routine. Would that be right?
Yeah, pretty much. I mean, I'd say the number one thing is don't be afraid to try a new product. Okay, because what will happen is you'll try a product, and your number one thing for me is the adhesive. The adhesive needs to be quite strong onto you. Now, for some materials might not suit your actual skin at the time. I can't say to a person that will suit you and that won't suit you.
Everyone's skin is different.
Everyone's different. I was fortunate in the bags I tried at first, and they just worked for me. And I pretty much stuck with them. I don't really have too many leaks and things like that. Things you can do to minimise that. What you call your base plate, that's where your stoma sticks out. Cut that to size, as close as you can get it, you know. And the more you can do that, the better a fit you get in on that.
So, have you had any complications, accidents?
Oh, leaks, yeah. So here's what can happen.
Yeah.
There's a couple of things.
What can happen?
Let's say you cut it too big.
Yeah.
Right. So now, if you can imagine, this is my stoma. Then outside here is the skin.
Ring. Yeah. Okay.
Okay. Now, if that isn't tight, what can happen is your feces and stuff like that can get into that gap. Okay. That can create sore skin.
Yeah. Yeah.
You don't want that.
Yeah.
So there's a couple of signs. You might get itchy. If you get itchy and you're feeling irritated, that's a sign to change your bag, or at least give it an inspection. So because you can usually see through and go, oh, okay, that looks clear or doesn't look clear. Obviously, it's probably going to be something you're doing private in bathroom, whatever. But yeah, don't be kind of sitting there thinking, oh, I've just got to put up with that. You haven't. Go and have a change. You might just need a couple of tips at first. There's a lot of videos you can watch. There's a lot of support out there that shows you how to do all this stuff now. Certain companies do that, so yeah.
And things go along swimmingly. Let's talk about activities of daily living, quality of life. I'll just be brazen as in, can you do everything?
No.
What can you not do?
Right, that's an individual basis.
Yeah.
Okay, so there's a bit of a fear factor which I'd like to kind of help the public with a little bit, and that's that you can't lift or do exercise if you've got a stoma. Okay, now
hold on, you can't lift. I get that because of the abdominal pressures, right? But you said you can't exercise. I mean,
right. Here's where I raise this. Okay?
Yeah.
When someone first comes out of surgery, they're pretty much told for 6 weeks to maybe even 12 weeks.
Yeah.
Don't lift anything, don't do this, don't do that. But the problem with that is, your mind doesn't work on negatives. If I say to you, don't think of a pink elephant, the first thing, the first thing you thought of. Now, it's the same thing with that. So we need to empower people to go, here's what you can do. Here's what you can do on a daily basis. And there are certain exercises you can do that help your core and abdomen in a safe, structured way. They help your breathing, they help your TVA muscles, which are lower down here, to support your stoma. And then you can start adding little bits in. You can start adding in the walks, you can start adding in, weight. If you want to do weight training down the line, you want to do weight training, you want to be, maybe you're a cyclist.
So you can, Matthew. It's just that it ought to be introduced gradually, incrementally.
Gradually. There's a line of debate, should we wear support wear or shouldn't we wear support wear? I don't think it does any harm, to be honest. So I would say, yeah, if you can wear support wear and it feels good, great. If you're feeling, if it's something really heavy, absolutely wear it.
Okay.
But more to the point, prepare your body.
Yeah.
So if just aside from this now, I'm a World's Strongest Man fan. I like watching all those guys.
Yes.
And you'll see they prepare their bodies as they're doing the lift. There's a certain way they breathe. There's a certain way they execute the lift, they breathe out. There's a certain way they lower the...
So are you telling me that with the new alterations to your body, you do certain things to just facilitate your body in a daily...
Absolutely. Even more so in my case, because I was kind of unlucky enough to get a hernia as well. So I've got... behind where the stoma is, there's a hernia and that pushes through. That can make things really difficult. But again, we need to move into a situation where we're saying to people, you have a hernia, but how can we help you safely exercise? How can we help your health long term? And that's a really, really big cause, because there's a lot of people out there thinking, this is it now, I've got a hernia, these surgeries, I've got to face another surgery, or I've got to try and live with this, and it's a hard mental thing to come to terms with. I even struggle mentally with that. I've been through a lot of things in life, but it was a difficult thing, because what happens is, if you can't see the progress path, it becomes very difficult, because you think, what steps do I take then? Yeah. If there's no outcome, if there's no end, I don't know how to do this.
As in, how do I get out of this situation?
How do you? Yeah. And I think the thing is, that's exactly it. When we think of a hernia, we think of a fix. That language needs to go. We need to think of, how can we live with?
Alter, adapt, adjust.
Yes. And it's the same thing with just having a stoma.
Yeah.
A stoma in itself is a type of hernia.
Yeah.
In the way that it protrudes.
Yes,
through.
Correct. Yeah, kind of.
So in order to create a stoma, in order to create a stoma, you have to push through the abdominal wall.
Yeah.
Okay, so it is, but it's not something to be terrified of, and that's the thing, and I would definitely say, again, reach out. There's a lot of great people out there that you can speak to about this stuff.
Are the stoma nurses helpful?
Yes.
Yeah, and so they're on the line, and they can give patients a lot of week-to-week kind of advice if necessary. I guess there's a helpline that you can ring and they get back to you.
Yeah, I've run the helpline, even recently.
Yeah.
With just a couple of questions I had on certain packs they were doing, and my skin and things like that. So they are really helpful in terms of that. Don't be afraid to give them a call.
So when you look back on it, you know how you think about something that's going to happen to you, like we were coming around to getting your head around it, and you look at it now, the reality, Matthew.
Yeah.
Was your imagination worse than what the reality was like?
It's an amazing question, but I can't even answer it, because in order to do that, I'd have to think of how my thought process was all them years ago.
Yeah, exactly.
And it's not, as I say, it's not a one time.
Yeah.
You go through the thought of having surgery on certain days. So for example, someone in an IBD flare today, they'd be sitting in a toilet, they've lost a lot of blood, and they're thinking, oh, surgery's coming up for me. The next week, they might be on a medication, they feel fine.
Yeah.
So we don't know. But what this is, it's a bit like a roller coaster. You get these highs, you get these lows, and that thought process of surgery, it's always in the background, you don't know. So how do I feel now versus how do I feel then is maybe a good question.
Because from a medical point of view,
yeah,
you're cured of your colitis.
In theory,
because we've taken away the organ.
That's another debate, because IBD theoretically genetics. So I mean, how you remove someone's genetics, but I get it that I haven't had the other bit, by the way, which is just might as well just throw this in there. When you have a subtotal colectomy, you're having your large colon removed, but a little bit remains.
Correct.
And that's called the rectal stump.
Correct.
Now, for some people, they actually develop something called diversion colitis, or another condition where they have inflammation in that rectal stump, similar to or like colitis or Crohn's disease, that type of thing. Now, for those patients, they can have what you either call a Ken bum or a Barbie bum, or what, I don't know if I'm allowed to say this, an action man ass. Which is you're allowed to say basically where they sew up that end.
Okay.
And that's another surgery they have. But I haven't had that bit. So I mean, because so far my rectal stump's been okay. One of the things that has been okay, but it's been okay.
So if your best friend or your somebody else was gonna go through what you were gonna go through, I want you to tell. Not me, I want you to tell them now what to expect, what's the best mindset, and how to adjust and adapt to life with the stoma. Again, God, I've thrown so many questions at you, but...
Number one, be kind in your thoughts to yourself. You won't be. You'll be very critical. You will be very blaming of yourself. Take a pause and just think to yourself, okay, I am going through a lot. Take a breather, realise that, and then just try and prepare yourself as best you can. Working on your physical fitness, okay? Speak to other people in the community that have got a stoma, an ostomy, right? Be mindful they're not always going to be a bed of roses, and you don't even want that. You don't want someone to go to you, this is beautiful, this is beautiful, this is beautiful, and you don't have that experience. You want a mixed bag. So you want to hear some of the positives, and on the other hand you want to hear some of the negatives, and that's going to empower you so much, because as you get your good days you'll be like, oh great, I feel good.
Yeah.
And if you get a bad day, you remember the one or two that said to you, oh, you know, by the way, I had this problem, and you can refer to that.
Yeah.
It doesn't feel as heavy. So that's really important, to kind of have that mix of people you speak with that have both a positive and a
perspective.
Yeah.
My perspective. Yeah.
Yeah.
What else would you say to them about, even directly about, you know?
I know this sounds really bizarre, but to as much a degree as you can, forget about it altogether.
Yeah.
And I know people are just going to laugh at that and think you're ridiculous.
Don't let it run the show, kind of.
Because a lot of the time, you know, as I say, what I'll do is, you know, I might have all these symptoms going on, get myself ready for work, I bang the support belt on, and I'm not Matt with a stoma, I'm just Matt. And I just do what I'm doing. I'll be in the kitchen cooking, or I might be cleaning my house, or I'm going to work, or I'm teaching my karate class, or whatever it is for you. But you don't always have to think of, I've got to do this, I've got to do that, The trouble is, it will be a life change, and it is a life change, but try not to let it overtake you, you know, because, you know, I think you're worthy of good life quality, everyone is.
Absolutely, absolutely. I like the fact that you said to be kind to yourself, because you're going through.
It's the number one.
Yeah, and so many. It's difficult to be sometimes.
It is, because we're, as human beings.
Yeah, we're really
generically.
hard, yeah.
I mean, if we work out together now.
Yeah.
And we lift weights, it doesn't matter what you say to yourself. You will naturally compare.
Okay.
You'll compare. So if your elbows out more.
Yeah.
If you're doing a bicep curl, or even more. Or you supinate at the top more.
Yeah.
You have these little comparisons that you don't even realise you're doing. It's the same thing when you have like inflammatory bowel disease or something like that. You might be comparing to someone who's like, oh, they're always living on a beach. That I need to be like them. I need to be in remission 24/7. But don't always believe everything you say on the internet.
Because it's all about you.
Yeah, it's a personal journey.
Be kind to yourself.
It's a personal journey for sure.
Well, Matthew, it was a real pleasure talking to you. Now, I've been informed. I thought I knew a lot, but I know a lot more now. Okay.
Everyone says this to me.
Yeah.
I usually thanks for not falling asleep, because that's a big thing.
Fantastic.
For me.
My eyes are opened even more.
Yeah.
And thank you for giving us your time and coming here today.
Yeah, absolutely awesome.
Thank you.
Yeah, thank you.